In the African context, there is also strong sociocultural pressure. Women are expected to appear strong and joyful after childbirth. Showing symptoms of mental illness can bring harsh judgment, shame, and even rejection from in-laws, partners, or family. This stigma prevents many women from speaking out, yet effective care is possible, and family support is essential as a protective factor. Hello, ladies and gentlemen. I am Dr. Natalie, psychiatrist and psychotherapist. Thank you for joining me today on this platform. I am making this podcast because many people in family go through emotional and psychological difficulties during their lives, but they rarely talk about them or do not seek appropriate help to cope with them. These are issues that affect our parents, our children, our brothers and sisters, our partners, and even ourselves. No one is spared. My goal is to share clear and reassuring information to help you understand mental health disorders. This way you won't feel alone in your journey and without resources or support. You will also gain some insight into what you or your loved ones may be experiencing. Ultimately, I hope this information encourages you to seek professional help, whether it is visiting a doctor, a psychiatrist, or a psychotherapist. This will allow you to receive the appropriate treatment and benefit from ongoing support. The purpose of this podcast is not to give you a direct diagnosis nor to diagnose your loved ones. Rather, it is about recognizing signs that may indicate a problem which should be addressed as early as possible by health professionals in an appropriate setting. And finally, to foster better collaboration between families, patients, and healthcare providers. So take a few minutes to follow me, settle in, and stay with me until the end, because this will be useful to you. Today, we are going to talk about perinatal disorders, meaning those that occur during and after pregnancy, and we will focus in particular on postpartum depression and the baby blues. Let's begin by defining what we mean by perinatal disorders. These are mental health disorders that can affect women during pregnancy. We talk about the prenatal and antenatal period. Or after childbirth, we talk about the postnatal or postpartum period. They include several conditions: the baby blues with heightened emotional sensitivity, irritability, frequent cheerfulness, emotional lability, which means changes in moods, which usually disappears within a few days without the need for medication. It is a natural adjustment phase, and if successfully managed, it does not progress into postpartum depression. The postpartum depression is characterized by persistent sadness, fatigue, loss of interest in normal enjoyable activities, and difficulty bonding with the baby. Studies by African authors report 15 to 30% prevalence of perinatal depression in pregnant women or women who just gave birth, depending on the region. Among Black African women, Perinatal depression expresses itself less through the classic depressive sadness and more through somatic symptoms. The mother will complain as such. I feel a weight in my chest, a heaviness in my head, abdominal or lower back pain. I am very tired. I don't sleep well at night. I am anxious or worried. These type of symptoms centered towards the body can be explained by the fact that in Africa in general, it is hard to recognize sadness as a sign of sickness. Therefore, women or people will focus more on bodies-centered complaints that will be recognized as signs of sickness. Then we have the antenatal depression. As the name suggests, this occurs before childbirth. We also have the perinatal anxiety disorders that are also part of these perinatal conditions. Then we have the postpartum psychosis, rarer but more serious, requiring urgent medical intervention. We will dedicate other videos to explaining these conditions in more detail. So why do these disorders appear? What you need to understand is that this is not a sign of weakness. These disorders are linked to real and explainable biological, psychological, and social factors. After birth, the body undergoes intense hormonal upheavals, which alter brain chemistry linked to mood. This is a particular event that not only affects the body, but especially for the first-time mothers, it represents a psychological, cultural, and social transition into motherhood. It is a period filled with apprehension, emotions, and expectations coming from family, from our partner, and even ourselves. This can create additional pressure on the mother's mental load. There are also mothers who already have several children or mothers expecting multiple babies who need even more support from their partner and family. As a matter of fact, in many societies, governments have put in place measures such as the maternity leave to provide financial and social support to parents. On the physical level, hormones play a major role. Hormones are messengers that carry information from one cell or organ to another, ensuring the body functions properly. In this period, significant hormonal changes affect the mother's mood, the way she experiences and expresses emotions, and her sense of stability and emotional well-being. They also regulate the mother's energy level and her ability to bond with her baby. Sleep deprivation plays a key role too. As we know, newborns do not sleep much at night and must adjust to this new environment, which contributes to maternal fatigue, recovery from the physical effort of childbirth, and the stress of new responsibilities such as caring for the baby add to this situation. This transition phase is therefore a source of stress for the mother, and her body reacts to this stress, sometimes without her being aware of it. The brain's stress response system can become overactive, and the mother's body may feel overwhelmed and unable to respond adequately to this stress. I will now deliberately break this down further so you can see that there is nothing mysterious about it, nothing to be ashamed of, and these signs are real. They are not simply a bad mood or a weakness of character. During pregnancy, the placenta produces very high levels of hormones, such as estrogens and progesterones, much higher than at any other time in a woman's life. These hormones stabilize mood and regulate brain circuits involved in stress and bonding. After childbirth, with the expulsion of the placenta, these hormones levels suddenly crash, dropping by 90 to 95% within a few days. This hormonal crash destabilizes neurotransmitter systems, leading to decreased serotonin, the happiness hormone, and dopamine, the pleasure and reward hormone, and a neurotransmitter called GABA, which has a role in calming and reducing anxiety. As a result, the mother may experience sadness, irritability, mood swings, or emotional numbness, meaning she is unable to feel much. She experiences flat emotions and apathy. She loses pleasure in previously enjoyable activities. She develops negative thoughts, feels pessimistic and hopeless. Her mental and physical energy is low, making it hard to care for herself, let alone the baby. Now let's talk about the dysregulation of the hypothalamic pituitary adrenal axis. We are going to call it the HPA. The HPA axis is the body's main stress regulation system. Normally, when cortisol, which is a stress hormone, rises too much, the system signals the brain through specific controlling hormones, which are the CRH and the ACTH. They ask these hormones to lower cortisol levels, helping regulate stress. During pregnancy, hormones like cortisol and placental CRH increase but remain somehow balanced by protective feedback loops. After childbirth, with the loss of placental hormones, this balance is disrupted. The brakes on the system weaken. Cortisol regulation becomes unstable. Levels remain high despite already being elevated. Research shows women with postpartum depression often have increased cortisol reactivity, meaning hypersensitivity, poor stress regulation, and impaired feedback mechanism. As a result, she can experience greater anxiety, agitation, insomnia, and feeling overwhelmed. Now, let's talk about the dysregulation of oxytocin, which is the bonding hormone. Oxytocin is a hormone of bonding and affection and stress relief. It is released during breastfeeding, skin-to-skin contact, like in the kangaroo method used in neonatology unit. So oxytocin is released through affectionate interactions. In some women, postpartum depression is linked to reduced oxytocin activity or lower receptor sensitivity. This makes it harder to feel reward and pleasure during bonding moments with the baby, such as caregiving. As a result, there is a difficulty in forming an emotional connection with the baby. She can experience feelings of detachment or guilt about not loving the baby enough or being a bad mother. Some mothers may avoid holding their babies or even feel hostility. In the long term, this can impact the baby's physical and emotional development. Their weight and height may be lower than those of babies of the same age. Together, this mechanism creates the emotional and physical picture of postpartum depression. Now, let's talk about risk factors and elements of prevention. Who is most at risk? Women with a history of depression or perinatal depression, history of anxiety disorders or bipolar disorder, whether it is a personal or a family history, meaning that you can have a father, a mother, an uncle, or even a brother or sister who is affected by one of these diseases. Women without prenatal care, those with obstetric complications or serious comorbidities, meaning those who have heavy illnesses occurring during pregnancy, and those with hormonal disorders are also most at risk. Women with unplanned or unwanted pregnancy, those who lack family or partner support, those who have been affected by domestic violence or have had stressful life events during their pregnancy or even before, those who have financial difficulties, those who lack rest and sleep, especially in the late pregnancy, those who are smoking or who use psychoactive substances, which mean substances that are addictive and affecting the brain functioning. All of these circumstances can increase the risk of perinatal depression. In the African context, there is also strong sociocultural pressure. Women are expected to appear strong and joyful after childbirth. Showing symptoms of mental illness can bring harsh judgment, shame, and even rejection from in-laws, partners, or family. This stigma prevents many women from speaking out, yet effective care is possible, and family support is essential as a protective factor. Prevention, both primary and secondary, can help avoid complications. Some preventive measures include regular prenatal visits, including screening for depression and anxiety, and psychological support, especially under stress. Physicians should refer pregnant women to psychiatrists early. Women and their partners should speak with healthcare professionals early before symptoms become severe. If depression is diagnosed before childbirth, medication may be prescribed, and women should be reassured. Treatment protects both the mother and the baby. Depression itself is a risk factor for suicide and premature birth. If you have concerns about medication safety, discuss them with your doctor. Women with a history of depression, anxiety, or major stressors can benefit from preventive support to strengthen coping skills, aid in decision making, and ensure social and family support. Social support is key. Staying connected with family, close friends, or support groups helps greatly. Healthy lifestyle habits are always encouraged. Regular sleep, balanced diet, gentle physical activity, meditation, and relaxation. Studies show that women who do not breastfeed have lower prolactin levels. The prolactin is the hormone of lactation. And those women have a higher rate of depressive episodes. Breastfeeding along with skin-to-skin contact boosts oxytocin and strengthens mother-baby bonding, making it protective. Even during treatment, women are encouraged to continue breastfeeding, with doctors choosing medication that pass minimally into breast milk. Treatment must be followed for the full prescribed duration, sometimes continuing months after remission. It should never be stopped without medical advice. Depression does not resolve in just a few days. It develops over time, and recovery requires the involvement of the patient, her family, the partner, the psychiatrist, the psychotherapist, and other healthcare providers for effective long-term support. If you or someone you love feels persistent sadness, anxiety, or stress after childbirth, it is important to talk to a doctor or a mental health professional. Partners, family, and friends play a crucial role, offering empathy, practical help with the baby, and listening without judgment can make a huge difference. This is a call not to blame mothers, but instead to provide understanding and support. For mothers themselves, self-care is not selfishness. Taking short breaks, asking for help, practicing relaxation, and following medical advice all promote recovery. Recovery is possible. With proper care and steady support, most women improve and thrive with their families. But when the illness is ignored, complications and the occurrence of new episodes and significant impact on both mother and baby can occur. As with all depression, suicide is the most serious risk to prevent. If you or someone close to you is in this situation, do not hesitate to consult a psychiatrist or confide in a trusted person who can help connect you with a mental health professional. Above all, take care of yourself and your loved ones. This was Dr. Natalie at your service. If you enjoyed this video, please give it a like, subscribe, and most importantly, share it, because this information can help many people and families and truly change lives. If you have questions, feel free to ask them. I will dedicate an entire episode to answering you. See you soon in another psychoeducation podcast.